Hello everyone, I am Dr. Arpit Sharma. I am going to discuss in short the implant portfolio. Why it's important is like we need to understand what are the different implants available in the market. We will focus basically on two companies, that is Advanced Bionics and the Cochlear, and their implants portfolio, and what implication do we have when we are faced with certain anatomical situations like IP1, IP2, IP3, which implants can be used and why it is used like that. So to begin with, we will discuss the advanced bionic implants. So advanced bionic implant has got two kind of a receiver stimulator. One is a Hi-Res Ultra 3D, which is a recent one, and the Hi-Res Ultra. So when you see the Hi-Res Ultra 3D, it's a newer one. It is the basic feature, it is the 3 Tesla MRI compatible with magnet in place. So that is the basic feature, and obviously it is more advanced with the technology wise also. As we are kind of in this age, as we are coming, there's a lot of indication for MRI. So eventually these kids who are implanted or the adults implanted may need to get a MRI done sometime in their lifetime. So that's why it always good when the implants that we are doing is MRI compatible, and especially with the newer and a better MRI versions like a 3 Tesla MRI. When it is compatible, it is always good for the patients. They are prepared for it. So then this multi-magnet assembly, the innovative alignment or the packaging of the magnets in the implant is such a way that it provides alignment to the magnetic field, and because of that it does not need to be taken out, and the patient can undergo MRI with the magnet in place. So there are small 5 cylinders in that, and which has got a kind of a movable titanium case, and which helps them kind of when the patient is put in the MRI, because of that it undergoes alignment. So this is the magnet. It has got cylinders like this. So which is in a movable disc, and when the MRI is off, the alignment is going to be like this, but when the MRI is turned on, that will get aligned according to the axis of the MRI. Apart from that, the Hi-Res Ultra is also one of the thinnest implant. It is the thickness of 4.5 mm. So because of that, minimal drilling is required for putting this receiver stimulator behind the cortical mastectomy cavity. A shallow 1 mm ramp is usually good enough to place this, which is suitable for both adults and the children, and it is also very good impact resistance also. It has got 16 active electrodes. Coming to the electrodes, they offer two kind of electrodes, the advanced bionics. One is a slim J, another one is a mid scaler. So the slim J is a lateral placement electrode, and the mid scaler is a perimodular electrode. So the slim J one is again a thin atraumatic lateral wall electrode. Mid scaler goes along the modulus. So a point to keep in mind, whenever the patient's cochlea is devoid of modulus, we cannot do a mid scaler electrode, like condition like IP3. Okay, so again all these electrode has got 16 electrodes plus one non-stimulating marker, and these are kind of can be reloaded. Especially the mid-scaler one comes with a stillet, but it can be reloaded again if any problems are there. So confidence of insertion is there because of the design. There is a slim electrode design which is with a tapered tip. But these electrodes, both slim J and the perimodular, has got a convexity on the outside. So the particular area, so what you can say, these are the half band electrodes. So these electrodes will be facing towards the modulus or towards the center or medially. So we should keep that in mind while inserting the electrodes. Again, because of this structure, it has got a proven cochlear structure preservation effect, and it's kind of a very atraumatic insertion is there, and which can be done through the round window approach or through a cochleostomy also. So this is electrode. When we see, it has got a blue marker which should be at the level of the cochleostomy or the round window. This is the tip. It is around 23 millimeter in length with some 3.5 millimeter kind of a curvature, and the thickness there is 0.55 mm and thickness at the blue marker area is 0.76. So the cochleostomy should be effectively around 0.8 millimeter, and 1.3 mm is the electrode spacing between the electrodes. And this is the wing. The wing should always be facing away from the incus. So this is how, because these electrodes are placed on this aspect, not on the convex aspect. So we should keep this in mind, and this area should be facing the modulus. And when it's facing the modulus, automatically the wing is going to lie inferiorly, away from the incus. Coming to the mid-scalar electrode, this electrode is coming with a stellate. So when we remove the stellate, it will kind of curl upon itself to hug the modulus. So basically, it's a modular electrode or a mid-scalar electrode, also known as a mid-scalar electrode. So the lateral wall electrode will be somewhere here, but the mid-scalar, high focus mid-scalar will lie somewhere here, close to the modulus. Both are atraumatic, very thin electrodes, and causes minimum damage to the inner structure of the cochlea. Both can be done through the round window or the cochleostomy. Okay, and this is a tip. This is the apical blue marker, and this is the proximal blue marker. Again, it also comes with a wing, which should be facing the away from the incus. This again, it's also one of the thinnest pre-curved array with which provides the lowest insertion forces, basically preserves the cochlear structure, and cochleostomy should be around the width of 0.8 mm. The apex, the diameter of the electrode at the apex is 0.5 mm and 0.7 mm at the cochleostomy level. Again, when we have said just in the beginning that we should be aware what kind of anatomical malformation, or if that is there, we should be aware which electrode can be used. So in cases where there is a partially ossified cochlea, we need a kind of a little rigid electrode. So because of the presence of the stellate, we should be able to use the mid-scalar one. In a severe ossified cochlea, sometimes it is difficult to kind of maneuver that, so because of that we need a slim J one. In a common cavity or a IP1 or IP3 where there is no modulus, we should use a slim J one. Because there is no modulus, we cannot use a mid-scalar one. And in a Mondini's, we can use a slim J one when there is less than 360 degree, and if Mondini's, which is more than 360 degree, we can use as a mid-scalar one also. So always any complex case we should keep as a slim J as a backup in the OR. So it is just a short animation which is showing the AB's receiver stimulator with the electrode. It is showing the different parts of it. There's a wing over here, blue marker, then the ring electrodes are over here. It doesn't have a separate ring, ground electrode. So this ring electrode provides the ground electrode, and this is the titanium case with this receiver stimulator, and this is the magnet. Again, 16 electrodes are there, and again has a very good impact resistance up to 6 joules. So this is the different other features available for advanced bionics. Namely, some of them are, there is something known as a Roger with the Roger Direct, which is kind of a portable walkie-talkie kind of a system to communicate with the implant or the kids. Again, the batteries are waterproof batteries are available, and integrated Bluetooth is also there, and there are other features like AutoSense Sky and dedicated pediatric processor. True bimodal hearing can also be done when one-sided ear is fitted with the hearing and another side with the cochlear implant, and the remote application also is useful when the parents can kind of control the implant through the so these are the various features which will be kind of taught in detail during the workshop by the company people also. It is a very short video showing the implant. It's a Slim J electrode, how thin it looks. It comes with the covering which needs to be removed, and you can see the wing over here and the blue marker. These are the electrodes. So blue marker should be lying at the level of the cochleostomy or the round window during the insertion, and wing is used for holding and inserting the arrays. A traumatic forceps or a AOS forceps or is normally used to hold the electrodes. Normally the wing is held along the axis, so that while insertion we are able to see the tip of the electrode. And as I have told earlier, the electrode should face superiorly towards the modulus. And this is how it will appear when we are inserting it. This is how it will go inside along the lateral wall. And the blue marker will be positioned at the level of the round window or the cochleostomy. So this is how it goes into the scala tympani. There is one more video of advanced bioning showing the implant. So this tip is measuring 0.5 mm in diameter, and the 16th electrode is around 0.7 mm in diameter with the blue marker over here. So this one is a mid-scalar electrode, and when you remove the stellate, it curls upon itself like this to be in a perimodular location. So after placing the receiver stimulator in the patient, securing it, then we go ahead and put it in the round window or the cochleostomy. The diameter of that should be around 0.8 mm minimum, with the electrodes facing superiorly towards the modulus, so that the wing is facing away. Okay, because this is a half bend electrodes. Electrodes are placed on one side of the implant. So this is how it will go inside. Once we go inside, we slowly start removing the stellate once we are at the level of the first marker, and we remove it completely when we are at the level of the second blue marker. So this is an insertion tool which used to be available previously, but nowadays is not anymore used, so we'll skip that part of it. Coming to the other company, which is a Cochlear, which provides a Cochlear Nucleus series implants. Again, they are also there in the market since a very long time. They have started with their implants since 1982, and over the period of time they have come up with the different implants with the 24 CI24 REST, which is one of their kind of very sturdy implant. It's there in the market since 2005. Recently they have come with the Profile, with the Slim Modular and the Profile Plus series, which is a kind of a newer generation implant, which is coming with a very thin implant, receiver stimulator, and a thin electrodes also. So the history of development of the electrodes is like initially they had come with a straight electrode, then come with a contour advance, which is a kind of a initial perimodular electrode, which used to come with a stillet. Then over the period of time they have come with the slim straight and the slim modular, which are the recent one. So when you look at the three electrode option that we have as of now, is one of the straight electrode, one is a contour advance that comes with a stillet, and then is a slim straight. So this straight again is a kind of a lateral placement of the along the cochlear wall. Contour advance is the perimodular one, which kind of goes inside. Once you remove the stillet, it will hug the modulus. And the slim modular one is the costliest implant as of now on the nucleus portfolio, with the advanced technological features also, is again a perimodular electrode. It is known as CI632. And the slim straight array is a 422. It's again a lateral placement electrode. So again it is also compatible with 3 Tesla MRI, and it is also one of the kind of a slim body of the receiver stimulator of around 3.9 mm, again which helps us avoiding putting a too deep a well. A slight ramp is that what's the placement of these implants apart from fixation stitches. So this is how a slim modular electrode will look like. It comes with the sheath. You first need to kind of pull it back so as to make it straighter, and then you put it through the cochleostomy or a round window. Once you start, the sheath is there inside, then you start withdrawing the sheath part of it, which will show an animation video in subsequent slide. So this is the contour advance electrode. Just some features of that is around 19 mm in length, with the tip measuring around 0.5 mm, and it has got 22 active electrodes. The diameter at the basal end is around 0.8 mm, with 3 silicon ribs over here. This is a slim straight electrode, which is also known as a 422. Again, the tip is 0.3 mm in diameter, and around the diameter at the basal end is around 0.6 mm, and it is around 20 mm in length. The active electrodes with 22 electrodes spread over 20 mm length. So this is a straight electrode, again 0.4 mm at the tip and 0.6 mm at the base, with 10 stiffening rings, but again 22 electrodes. So this is one of the advance of stylet technique.
The contour advance electrode is
animation video
and then held straight for insertion with the stilet.
Of the
this animation shows how the electrode plus stilet are first inserted into the cochlea.
Contour
Then,
advance one.
as the electrode is advanced off the stationary
will go
stilet,
inside.
it curls around the modulus.
Once this is inside, then we'll slowly remove the
The
stilet.
contour advance electrode finally settles in a perimodular position, with the silicone in its coiled resting state
From the
and with the
implant.
platinum contacts facing towards the modulus.
Again, it is a half-bended electrode.
For proper electrode placement, it's crucial that the cochleostomy is located over the scalar
As
tympani.
mentioned, that we need to do the
Once the
cochleostomy
electrode is
so
introduced
as
into
it
the
is
scalar
going into
tympani,
the scalar
the
tympani, and
electrode
this
moves
is how the
smoothly through the
implant
cochlea
animation
with
video
minimal
showing
pressure
how the
from
implant
delicate
when it goes
tissues
into the
cover the
cochlea.
walls of the lumen. Cochlear
This is also one of
electrodes
the
must
other views
negotiate
how
a
it
complex
will look
three-dimensional
like when we
path through a lumen lined with
negotiate for the
delicate
complex
tissue.
three-dimensional path
The shape and
through the
flexibility
lumen
of the Contour Advance electrode,
of
along
the
with the
cochlea.
AOS insertion technique, have been designed to allow the surgeon insert the electrode smoothly into the scala tympani without dislocation of the basilar membrane or entry into the scala vestibuli. Straight electrodes rely on
This is a
reactive
scalar
forces
view
from
of
the
the
lateral
straight
wall
electrodes,
to
how it
steer
will
them
go.
around the turns of the
Normally the
cochlea.
straight electrodes go along the
Stiffer
lateral wall.
electrodes generate higher forces, while the sloping
And
wall
since
of the
they
scala
stiffer, they
tympani
generate little
tends
more
to
of
direct the
shearing
electrode
forces
upward
when they are
towards
going
the basilar
inside and
membrane.
scraping through the lateral wall.
If the tip of the electrode lodges in the soft
But
tissue of
if
the
it
lateral
goes
wall,
into
and if the electrode
soft
is
tissue
inserted beyond
and
this
if it
point,
is inserted beyond, it
can
may
tear the
just
basilar
migrate into
membrane
the scala
and end
media
up
or
in
the
the scala
vestibuli
vestibuli.
when you are doing a kind of insertion with the force, if when it is any resistance is there.
In the AOS technique, the electrode
This
is
is
held
also one of the
alongside
animation when you're
just
using a
behind the
contour
ribs
advance.
with
If
the
you're
AOS
using your
forces.
right hand,
The electrode is introduced
how you will
until
place
the
it
white marker
through
is
the
at the
right
level
hand,
of the cochleostomy.
the whole assembly along with the
Another
stillet,
pair of forceps
and you will
is
use
then
your
used
left
to hold
hand
the stillet,
to slowly
and
withdraw the
electrode is
stillet
advanced
of
off
the
stillet
implant,
while the stillet is held immobile.
simultaneously pushing the
When the marker
implant
ribs are at the
inside as well.
cochleostomy, the electrode is held fixed and the stillet is completely removed. The AOS forceps are then carefully released and moved away from the site. We recommend the use of the AOS forceps as they provide a stable grasp of the electrode.
Again, it's just
In
the
the AOS
left-handed.
technique,
If you are using a
the
left
electrode
hand
is
for
held along its
insertion,
axis, just
how you
behind the
will
ribs,
insert the
with the
implant
AOS
with the left
forceps.
hand, while you will remove
The
the
electrode is
stillet
introduced until the white
with
marker
the
is at the level
right
of the
hand.
cochleostomy. Another pair of forceps is then used to hold the stillet, and the electrode is advanced off the stillet while the stillet is held immobile. The Contour Advance electrode is moulded curled and then held straight for insertion with the stillet. This animation
Okay,
shows
so
how
that
the
is it.